Wow, it's quite a crowd here. I didn't expect all of this, but thank you for coming. Sarah told me to tell you that we will have questions afterwards. My thoughts on this topic changed over the last couple of days. My mother-in-law was recently admitted to hospice here and passed away earlier this morning around 2 a.m. And it made me think. I was thinking while I was sitting there in the hospice house about the topics that were on here. You know, healthy aging is something I talk about every day with all of my patients. It is, I thought about going through the systems and talking about the different systems of, the heart, the brain, and everything. And I'll go through a little bit of that, but a lot of this is, I think this is a very appropriate topic for our time. And it's interesting, as a physician, what I went through for the last 48 hours really changed my look on things. And I'll explain that as we go forward. So what do we look at when we look at health? Most of us want to be active physically and mentally. We want to be able to do our own, what I call your activities of daily living. You want to be able to take care of those things. You want to drive. You want to be participating in church functions and doing the things you love doing. When I look at these things, I think most of us want to have a better understanding of what we can do individually to try and keep ourselves healthy. So when I look at these things, I'll break it down the way it was in the syllabus I was given. If you look at aging, there are lots of changes that we experience. I'll start with the first ones from a cardiac standpoint of view. What happens with the heart as we age? If you look at the heart, your heart's going to beat about 100,000 times a day. It's about 7 million times over 70 years. Now, you can get structural problems with the muscles. You can have valvular problems. Valves, if they open and close that many times over the years, they can get worn. They can get stenotic. That causes problems with pressure changes in the heart. People can develop heart failure and things like that. One of the things we look at, and I know most of you, if you've talked with your doctors, if you have hypertension, why do we get excited about hypertension? Well, hypertension is stiffening of the arteries. The arteries get stiff, the heart has to work harder to push blood through the arteries. If that's the case, then over a long period of time, the heart can adapt to that, but long term that can lead to structural fatigue in the muscle of the heart and lead to heart failure and other problems, irregular heart rhythms, heart attacks. We talk about coronary artery disease specifically with heart disease in general. Coronary artery disease, or hardening of the arteries, as most people may call it, is a thickening and stiffening of the vessels. Our blood vessels should contract and relax very easily. They're very compliant, and that's why when our heart beats, if we have an elevated blood pressure, typically that's because our arteries are stiff and they're hard. It's harder to pump blood through a stiff vessel than it is to pump blood through a compliant vessel. So we try to get the blood pressure down so the heart's working more efficiently and is not as stressed. This has profound implications throughout our body. People come in and say, well, why am I having trouble with walking, or why am I short of breath? These changes, some of them, am I not close enough? Sorry about that. Can everybody hear me back there? Okay. So I could go on and on about this, but basically, if you look at the changes in the vessels, those can cause changes with the blood pressure that can cause heart problems. That's a part of aging. You look at exercise tolerance. There are a lot of reasons people can't exercise the way they used to. They're short of breath, or they get winded when they're walking. A lot of that's due to deconditioning. If we look at the lungs, there are lung-related changes as we get older also. The lungs are exposed to all kinds of toxins as we get older. Anything from pollution to car exhaust to hairspray to all the other things we're exposed to on a daily basis can affect the lungs. That can lead to scarring later in life. Smoking is probably the biggest thing that we see, although it is less now than it used to be because less people are smoking. But we get changes in there. You get scarring, infections. We get upper respiratory colds. We get pneumonias. That can lead to scarring and make it difficult to breathe as we get older, as we age. People that have had one episode of pneumonia are more likely to have pneumonia again as they get older. Part of what we see with all of these issues is it's not just one thing that leads to aging. It's a number of things. It's heart problems, it's lung problems, could be musculoskeletal problems. As we age, we get into trouble with joints. And I know I'm 54 and I'm already having difficulties with arthritis, but I've realized that I'm stuck on a computer 90% of the time. I'm not exercising like I should. And what I found after I go in to see other people about this is I need to exercise. If you look at the changes from a musculoskeletal standpoint of view, if you look at changes from a musculoskeletal standpoint of view, most of the problems we see there are deconditioning. If you have good muscle tone, you have good tight ligaments, the joints are in better alignment. You have less wear and tear. It's very important for us to stay active. It's very important to keep muscle tone for all the groups. A lot of people just want to walk, and that's great. But I also encourage people to use their upper body because it helps with all of these muscles support the shoulder structure. If you don't have good muscle tone here, then you have more arthritis in your upper body. I tell my patients all the time, we talk about cases, and there's a study that came out in the British Medical Journal probably about 10 months ago looking at people that are long livers in England, people living in the late 80s and late 90s. And they looked at these individuals and they tried to determine what was of significance that led them to lead such good, healthy lives. Only one thing made statistical significance, and that was they were walking for 30 to 40 minutes, 5 days a week at a brisk pace. Now your pace may be a little bit different from my pace, but what they were doing is getting their heart rate up and keeping it up for 30 to 40 minutes, 5 days a week. They showed a 20% decrease in all-cause mortality, a 24% decrease in cardiac death. That's tremendous. It really makes a big difference. Talking about bones, as we age, especially for women, there's an increased risk of osteoporosis. The reason we get concerned about osteoporosis is because if you take a 70-year-old woman, falls and breaks a hip, their mortality rate's 50% in the next 2 years. It's not 5. I'm not sure how to handle that. Is that? But so it's horrendous. And so that's why we really push staying active. I can fall and break a hip, but coming off the stage here, but the reality is that a lot of times when someone's older and they fall and break a hip, they don't regain where they were beforehand, and then they become weaker and more sedentary. One of the biggest things I wanted to touch on too, besides the musculoskeletal and cardiac issues, was the neurology or the neuro issues that we face as we get older. A lot of us worry about as we get older, we're not going to remember things, we're not going to be able to take care of the things we want to take care of. If you look, most of us will lose a small degree of memory as we get older. It levels off at about age 90. 60% of all 90-year-olds have a degree of memory loss. There are several diseases out there such as Alzheimer's, or we call it organic dementia, or Lewy body disease, or Parkinson's disease, that have memory loss associated with them. Well, if you look at those diseases, well, there are other diseases as well. You may be familiar with concussions causing trauma to the brain and memory loss disorders down the road. Strokes can too. any damage to the brain tissue can lead to a memory loss disorder down the road. And those patients will actually lose memory faster. And it's usually short-term memory. Long-term memory actually gets a little bit better. And I always joke with my patients, they can remember what they had for breakfast 25 years ago on Christmas morning, but they couldn't tell me what they had this morning. And the key, though, is identifying those patients and starting them on medications. There are good medications now that dramatically slow the progression of memory loss. Those medicines are not, they don't change mortality, but they are effective in helping people maintain their quality of life by keeping them independent in their own home, doing their activities of daily living as they would want. But I could go into more detail on all of this, but I think when it comes down to the last thing I looked at and wanted to go over was preventative measures. How do you prevent all of this? Well, some of it we just can't. Degeneration, we get degenerative disease of our joints just from wear and tear. But we do know that if you exercise, you have less arthritis. You actually feel better. You're less likely to fall. I send patients to physical therapy because when you start losing muscle tone in your thigh muscles and hip girdle muscles, your ability to stay stable and ambulate without falling drops dramatically, and those patients are at a much higher risk for falls and fractures. So the number one preventative tool that I recommend for everybody is exercise. But it doesn't have to be strenuous exercise. I used to think I had to go to the gym and work out for 2 hours. Well, I never made it to the gym, so I always felt guilty. But if I get a chance, I go out for a walk now, or I'll jump on a stationary bike, or I'll go swimming, or something like that when I can. I used to think, oh, well, I don't have time, I'll just do it another day. Well, I'll go do something for 15 minutes if that's all I have. But it makes a big difference. I see lots of patients, and I use my father-in-law as an example. He had aortic valve surgery when he was 69 years of age. He was in the hospital for 4.5 months. He was on a ventilator, paralyzed for 4.5 months because his lungs were so bad. Well, when he woke up, he couldn't even move his hands. Well, so what did we do? We moved him for him. And as he was on the ventilator, if the commercial came on the TV, we made him do exercises. He didn't like us very much, but the reality is that every time, even when he came to live with us after he got out of the hospital, if a commercial came on, he had to give us 10 of something. But if you saw him today, 10 years later, you'd never know he was ever sick. And he's better than he was before, but it was just conditioning. So I don't care how old you are, and I don't know if John Grubb's here, but I use Colin Grubb as an example all the time. Look at Colin. She walked everywhere. She was in great shape. And so, Dr. Frank Schaefer, who retired just prior to me coming to town, and I inherited a lot of his patients, he still walks. So, he can't walk as far as he used to, but he is still active. And so that's what's kept him going. Now, one of the other things besides exercise is healthy eating. And I go into a lot of details with patients about proper nutrition. The American diet's too heavy in refined sugars. Portion control is an issue, but proper diet is extremely important. Good nutrition. If you don't have good nutritional stores, your immune system doesn't work well. And if that doesn't work well, you're at higher risk for pneumonias and infections and things like that. So that's a very important thing. Next thing I'd like to tell you about is preventative as far as vaccinations. We always talk about different vaccinations. The key are the ones that, you need the flu shot every year. We use the high-dose flu shot for everyone over 65. The studies show that you have a better, what we call an amnestic response, or a better response to this dosing. So that's what we use for everyone over 65 now. So I encourage you, whether you get your vaccine at your doctor's office or at the Walgreens, get the high dose. The next vaccine would be your diphtheria, pertussis, tetanus. Now, Medicare doesn't pay for pertussis, which makes no sense to me, but pertussis is a very important one for you who have grandkids. Pertussis typically is a very dangerous infection, or whooping cough is what it's called, in newborns and young children. So I've had a lot of patients come in and tell me, well, I have to get this because my kids won't let me around my grandkids. So I think that's a real important one, and that's one you need every 10 years. The pneumonia shots, there are two of them, Prevnar and Pneumovax. Prevnar 13 is a 13-valent vaccination against Streptococcus pneumoniae. That's the most common cause of pneumonia in adults. It covers 13 of the 140 serotypes of that one bacteria. Pneumovax 23 covers 23 of the 140. So roughly with the two of them, you're getting 36 of the 140. Now you may say, well, that's really not worth it, but those are typically the ones that bother us. And as a matter of fact, we give Prevnar to all kids now, and it lowers their rate of ear infections. So it's a pretty good vaccine. The Prevnar is once after the age of 60, usually around 65. Then the Pneumovax is given second, and then there's a booster on the Pneumovax 5 years later. The last vaccine I think is probably one of the most important ones, and that's your shingles vaccine. People come in and they'll say, well, Doc, I never had chickenpox. And I'll say, well, gosh, 90% of the American population is walking around with this virus in their bodies. Whether you had chickenpox or not, it's once you have the infection, it hides out in the nerve roots in our back. So later in life, it can come out as an infection. And when it does, it comes out as shingles. I got up one morning about 5 years ago, had two little lesions right here, and started on the antiviral therapy that day, and it was gone within 2 days, which was great. Most people won't start the therapy because they don't realize what it is. If you come in 3 or 4 days and you've got this rash extending around your body, the medication will not work. And the pain that can come from that, it's a minority of the patients that get the post-pain syndrome. We call it post-herpetic neuralgia. The pain can be intense. It'd be like a lighter, just taking a lighter under your skin, and it doesn't go away. It's constant. It can last for weeks to years. I had one gentleman that came in, it was the middle of the winter. He had everything, the sleeves of his shirt and his coat cut out. He felt, the cold felt better on his arm than anything touching it. And it was years before his arm, it was still very sensitive, but you know, it was very debilitating. I've seen patients come in who were functionally very healthy, and it runs them down. And it can, and the problem we run into as we get older, we get one thing, and then we get run down, and we get another thing, and it's just a vicious cycle. So that's why I really tell everybody, there's a shortage of the vaccine. You can only get it at your pharmacy, basically. But I tell patients it's a 2-stage vaccine. It's not a live virus vaccine. It's safe. So even people with leukemia and things like that, or immunosuppressant therapy, can get it. And I think it's a very safe vaccine. I will tell you though, it made my arm sore when I got it. And my arthritis flared up a little bit. I took Tylenol around the clock and it was gone within a couple of days. The next time I got the vaccine, 2 months later, it was fine. I didn't have any symptoms. But I've only heard of a few people having any problems with it. Last thing I'd like to go over, and I think Derry wants to go over this too. I'm not sure about this orange form Sarah was talking about. Don't mistake it for the goldenrod form. And I want to talk about advanced directives. So I sat down with my mother-in-law recently and talked with her about what she wanted to have done. You know, did she want to be on a ventilator? Did she want to go in the hospital? Did she want to have IV antibiotics? Those things. I was always a big proponent of the DNR form. And it's a good form. But basically, it only states two things. One, I don't want to be on a ventilator, or one, I don't want to have a CPR done or cardioversion if somebody finds me down. As a healthcare provider, I tell patients, you have to have 2 copies of this. One on your refrigerator, because if EMS has called your house, first place they're going to look is your refrigerator. If they see this, they're going to treat you, but they're not going to put you on a ventilator or do CPR. The other is to keep it in your pocket or your purse, things like that, because if you do go to the hospital and we don't know it, we'll do everything. And we don't want to do that if that's not your wish. Sometimes you can't get away from that, but that happens. A more in-depth form is called the MOST form. This form tells us as a provider, do I want antibiotics? Or if I'm sick and I have pneumonia and I have to go on a ventilator, I don't mind that as long as I can come off within a timely fashion. If someone told me, Doug, I've got pneumonia, or you've got pneumonia, and you're going to be on it, you're going to have a trach, and we're going to have to send you to a specialized nursing home with a trach for many months, I might not want that. So this form is even more in depth as far as, what do I want? But these forms are good, but I also recommend my patients get a living will. Something you should discuss with your family and have your attorney draw up that basically states these are the things I want done. And why this is important, it's important if your family understands what you want. Sometimes there are discrepancies in what family members want for their members. Mom comes into the hospital, she's sick, she's on the ventilator, she's been there for weeks and weeks, and things look bad, and the daughter or the son that's not been in the picture for 5 years comes in and says, hey, look, she wants everything done. I can pull out this form and say, hey, look, no, we've had this discussion, this is her desire. And I think those are important things. So if you go back and think about healthy aging, we all want to be prepared for the worst, because that is going to happen eventually for all of us. But we want to make it as painless as possible. We want to respect the wishes of our patients and you guys as far as what do you want? What is a good quality of life? Your quality of life or my quality may be different. And I think that, it was just like with my mother-in-law. She finally got to the point with her illness, she wasn't having the quality of life she wanted. And that's why we didn't fill this out, but we knew exactly what she wanted. And I think that going through this has really opened up my eyes as far as helping me understand what my patients are going through. One of the things I will tell you is that Derry and I were just talking about hospice, and I remember talking to Tippy Miller just before she passed, and I couldn't help but the last 2 days walking around the hospice house thinking about all the work they've been done to bring that to fruition. What an amazing place. And my wife is a nurse, and she's trying to help my mother-in-law, but all the burden's on her. We should be able to do this, and she felt guilty that she couldn't do certain things. Finally, she got to the point where we really it forced us to have to do something. And I talked to Dr. Amin, and we were able to get her to the hospital and get her stabilized, get her out of distress, and then go straight to the hospice house. And that is a wonderful facility. And I as a healthcare provider, refer people there, but I didn't do it fast enough. If I'd known now what I knew then, I would have done this weeks ago. And so I think that, I want to put that in your mind also, to understand that, sometimes people want to stay at home and they want to be cared for at home, but the burden of doing that is so taxing on the family that they can't be the family. They can't be there to support the individual. And that was a very eye-opening experience for me. I kind of went through all of this really quick. It's a big topic. Afterwards, we can answer any individual questions you guys have. Okay? Derek?
I just want to say a welcome to all of you too. It's been a real learning experience being on this team with some very remarkable people and some very, very specialized abilities on this team. One of those is our next presenter, Derry Caldwell. She's certainly a name that a lot of you recognize, but she was a wonderful person to have on our team. What a valuable resource. Derry, that I will be introducing, got her bachelor's degree from Chapel Hill. But for you Duke fans, she got her master's in nursing from Duke and went on to get her PhD in health sciences from Columbia Pacific University out in California. And she's had 40 years of experience as a nurse and as a healthcare administrator, recently retired, some of you may know, as the CEO of Rowan Health. No, Novant Health Rowan Medical Center. Can we say hospital? So she was our CEO there, and certainly she continues on in a consulting way and has been very active in our community. She's a member of our church as well as her husband, David. They have 2 sons, a granddaughter. She's an amazing person, and she has a lot to share with you. So we're very, very excited to have her. So you can welcome Derry Caldwell.
Okay, so we're coming down the home stretch. Turn down some. And one of the things that we know about most human beings is we have 3 big questions in life. The first question is, what will I die from? What will be my cause of death? And I think Doug did a great job of kind of going through the body systems, and you know your own body, and you might be thinking about that. But the other 2 are, when am I going to die and how will I die? And so I'm going to talk a few minutes about when you're going to die and how you will die. Okay? So one of the things you do have some control over in many aspects is when will you die. Now, if we have an unexpected death, if we go out of here and get hit by a car, we didn't have a whole lot of control over that unless we didn't put on our seatbelt or one of the safety measures. But as far as aging is concerned, you do have some control. Most people want to age in place. They want to stay in their home. They want to stay independent for as long as they possibly can. And I have an entire page full of tips and tricks to help you maintain your independence for as long as possible. But as I was putting those down, it occurred to me that that's probably a whole nother class. So I won't go into a lot of detail about that other than to say, number 1, don't climb. Don't climb. Because you heard what Doug said about falling, and falls contributing tremendously to mortality. And we all know people that were decorating their house for Christmas and fell and met their demise. And so just really think about that. But there's a whole list of things to help you stay independent in your home. And then there are a whole lot of options in our community. We are very blessed in this community to have as many options for aging as we do. In fact, the city of Salisbury just received certification in the state of North Carolina as a certified retirement community. I don't know if you knew that. But we have wonderful facilities that offer independent living, that offer there's a spectrum of care. So you're in your home, let me go this way. You're in your home and you're independent. And then being in your home maybe gets a little bit too much for you. So the next step may be going to an independent apartment. And we have those in our community. You still live independently, you do your own thing, you drive, you do whatever you want to do, but you have a little bit of a safety net there with help with food and cleaning and different things like that. Trinity Oaks has that, and there are others in the community as well. So then the next after that would be in-home services. And those can occur whether you're in an apartment or whether you're in your own home. And that's where you can have home assistance. My Uncle FJ lived to be 94 years old, and he was my idol. He was my role model. And he had Home Instead that would come out to the home, help him get in and out of the shower, and take him to the grocery store. And he called it his driver. His driver would come. And it allowed him to stay independent much longer. And you don't have to be homebound for those services, but they're not cheap. So you can expect those services to run in the neighborhood of about $20 an hour when you have someone come in to help with certain things. Then, once you can no longer leave the home easily and you are declared homebound, then you can get services through home health care. And those can be aid services to help you with your activities of daily living, such as bathing and preparing meals and so forth. We have a wonderful Meals on Wheels program in Rowan County that is tremendously helpful to many people. But it could also be nursing care. So if you have certain things going on health-wise that you need a little bit of help with, then the home health nurses can come in as well, but you can still be in your home. But the ticket there is you have to be homebound in order for Medicare to cover it. So next after that is then assisted living. And that is something that really, when I was coming along as a nurse during my clinical days, we didn't have assisted living. You either were in your home or you went to a nursing home, and there was no assisted living. And assisted living is kind of a new thing in the last 20 or 30 years, where you may go to a facility to live to have help there with certain parts of your activities of daily living, including administering medications. But it is not a skilled nursing facility, and Medicare does not cover assisted living. So the cost of assisted living sometimes can be pretty steep. And that's one of the things that we grapple with trying to help patients figure out where they need to be. And then the next step is skilled nursing. And you go to a skilled nursing facility or a rehab facility when you have need for nursing care. So you have to have something going on health-wise with you that causes the nurse to need to be involved in your care. It might be wound care, it might be physical therapy that has to be involved, as Doug said, with helping you rehab. If you've had hip surgery, you may go to a rehab or skilled nursing for a period of time to get you back up on your feet and gone. So that's kind of the spectrum of care. But then you get to the point where whatever is going to be your demise begins to show itself. It might be heart disease, it might be lung disease, it might be kidney disease, it might be cancer. It could be any number of things. It does not always have to be cancer, but there are other things that have kind of an end diagnosis to them that the doctor can say, yeah, this is probably what's going to get you in the end, is this particular thing. And so in those cases, we also have options, and this is where you really have control. And there are two areas. One is palliative care and one is hospice. And the difference between the two is palliative care is a method of caring for you. Hospice is actually a Medicare benefit. And a lot of people don't realize the benefit that you have with hospice. So I'll get to that in a minute, but first I want to talk about palliative. Palliative care is an option that you can talk with your physician about, whether it's your primary care physician that you see all the time, or if you're in the hospital with one of the hospital-based physicians. Palliative care is a particular science of care that specializes in comfort measures. You can still be receiving treatment for whatever's wrong with you, but at the same time have palliative care to help with the management of your symptoms. Shortness of breath, difficulty eating, weight loss, pain, and pain management. Comfort measures are all embroiled within palliative care. The one thing I will tell you is everybody's not a palliative care specialist. And one of the areas that has developed in healthcare is official palliative care nurses and palliative care physicians. And there's actually a board certification now for physicians in palliative care, because not just everybody's good at it. And there are people that are very good at it that can make your lives so much more comfortable. There are a number of organizations in our community. I brought some information for the Novant Health that's back in the back of the room, but we also have Trellis, we also have Pruitt, we also have a number of other organizations in our community that can provide these services. Comfort measures is just what it says. Those are things that we do to keep you comfortable. Comfort measures does not, when the doctor says, okay, we're just going to move to comfort measures, that may mean we're not going to try heroics. You may have decided you don't want to be resuscitated, you don't want that ventilator, you know this is getting to be a problem for you, you don't want all this stuff done to you, and you don't want to be dragged back and forth to the hospital all the time. But neither do you want to be shoved into a corner to die. That is not what comfort measures are. Comfort measures are things that are unique that can be done to make you more comfortable as you go through your disease process. When you have comfort measures, it does not mean you're not going to get food. It doesn't mean you're not going to get water or hydration or any of those things. Comfort measures often include things like massage therapy, certain kinds of baths, aromatherapy, different things like that to help you cope, to deal with your anxiety, to deal with your spiritual needs, and to make you more comfortable. Then we get to hospice. Now, hospice is probably the most challenging area I've ever worked with in healthcare because there are so many myths and disinformation about hospice. First of all, hospice is, like I said, it is a Medicare benefit, or if you have insurance, you may have a hospice benefit with your insurance if you're not yet on Medicare. And when I say benefit, I think people don't really get what a huge benefit it is. Because once you are enrolled in the hospice program, they take all the burden for most of what you're going through away. They arrange for your medication, so you're not running back and forth to the pharmacy. They deal with everything you need once you become a hospice patient. And as Doug said, with your wife, it takes the burden off. So if you're trying to be the family member and the loved one, and you're also trying to be the caregiver, and it's overwhelming, the specialness of hospice is that burden is taken away and you're allowed to spend that quality time with your loved one at the end. And most people do not refer to hospice or don't choose hospice soon enough. Typically, the rule of thumb is when we're starting to talk about is this patient a candidate for hospice, what we typically will say is, Dr. Shellhorn, would it surprise you if this patient died within the next 6 months? And if the answer to that is, based on the trajectory that they're going down, that wouldn't surprise me. Well, then they can qualify for hospice, typically. So it's not, you don't wait till the week before you die, you don't wait till 3 days before you die. If you do that, you have just basically given up all your hospice benefits that you could have been having for the many months that you may have enjoyed them. So I think that's the biggest myth. The other biggest myth is that once you go to hospice, they give you a bunch of morphine and just basically euthanize you. That is not true. I have had a number of family members die in hospice service. I was there. That is not what they do. Yes, they do provide comfort. They try to keep the patient out of pain. They try to do any number of things to make the death experience one that is what that patient wanted it to be. As Doug said, we're all going to die at some point, but we do have a little bit of control over how that goes. So with the hospice care, you also get comfort measures. The only difference really between hospice and palliative care is that once you elect hospice benefits, you no longer receive curative treatment. So for example, if you're a cancer patient and they're giving you chemo to try to make the cancer go away, then as long as you're still actively treating the cancer to get it to go away, you may not qualify for hospice. But once you decide enough's enough, I can't go through this again, I'm not doing it anymore, then you can qualify for hospice. There are certain treatments that we use sometimes that are palliative. Sometimes if you have a tumor that's blocking your GI system where you can't digest your food, we can do some radiation to shrink the tumor to make you more comfortable. That might be considered palliative. So just because you go to hospice doesn't mean you can't have anything anymore. And a lot of people get confused about that. But as you experienced, the biggest thing I can say about hospice is when your time is starting to be on the horizon, really think about that benefit and how you can maximize that benefit to your best way to make you in control and to give you the comfort you need at the end of life. I wanted to bring up, Sarah put out on the back table, she got these for us, and if you, when you registered outside, if you didn't get one, pick one of these up. This goes into a lot of detail about a little bit more in depth than living will and that sort of thing. It gives you the opportunity. This is a great piece to sit down with your family and talk about and to say, hey, you know, I went to this class at church. While we're thinking about it, let me just go over with you one more time what I want. Because as Doug said, the kid from California that hadn't been here in the last 5 years to do anything shows up and starts trying to tell everybody what mama wanted when they might not have a clue what mama wanted. And we've seen that many times. And I use California because I lived there for a while. So, but this is a great tool to use as a conversation piece with your family, to go through once again everything that you want or don't want. And everybody's unique in what their desires are. And then the most form, this one, this hot pink one, these are available at your physician's office. And some mechanics of this is it has to be renewed annually. So if you've got all your wishes on here, and yes, I want this, but no, I don't want a tube feeding, or yes, I want this, all of this is great. Your doctor signs it, and that's what makes it a medical order, because your doctor has signed it, MD. But it's only good for a year. So each year when you go in for your physical, you got to update it, and you can use the same form and he just writes on the same form, or you can redo the form, but it has to be updated annually to be valid. So those are some of the highlights about the spectrum of care that we have available to us, and hopefully that gives you some food for thought. And at this point, I'm going to ask Bill Gregg to come back up. And Bill started us off in session 1, and he's going to close us out today. So if you'll come forward, Bill. Thank you.
This has been a wonderful series, and I really am privileged to have been a part of it and to have kicked us off and now bring us to our conclusion. You've died. It's done. There's no more for you to do. But before you get to that thing, there is one thing that's really helpful. I'll go back. Sarah mentioned that form for funeral arrangements for First Presbyterian. The conversation about your funeral is really important. And there's some homework you can do before you do it. That is, go visit funeral homes. There's more than one here. Go visit them. Ask them what they do. Ask them how they do it. Get them to show you the price list. Can you do a pre-planned, prepaid for funeral? If so, how do you do that? What are your options if you're going to be cremated, or are you going to be buried? Or do you choose to have the body at the funeral in a casket that you rent? And then they take you back and cremate you and give your family the urn. There's some decisions to make, and there's some options. You help your family not fall into the trap of, oh, this is the last thing you'll do for mom or dad, and so you want it really to be spectacular. And $12,000 later, you have a bronze casket that's going to be put in the ground, and nobody's ever going to see it again. Let me discourage you from that option. What you can do is think about what is appropriate for you, the way you would like your final, formal, public end to be recognized. The thing about a funeral is that it's not about you or me. We're having a funeral because you or I have died. but it's about your friends and family. It's about providing a means for people to bring to conclusion a relationship that has been of value, a relationship that has been a relationship of love, a relationship that has been a blessing in your life. And we human beings need to do that. There was a time in the 16th, 17th century where you died, they went and got the box, put you in it, walked over to the cemetery, dug the hole, put you in, and went away. And that's not good enough. So think about it, whether you want a graveside only or whether you want something at church. I mean, from my perspective as a bishop, the proper place for a funeral is your church. It's where you've prayed, it's where you've had your children baptized, it's where you got married, it's where all the significant things in life tend to take place. And a funeral may be because of us and for the benefit of our friends and family. But the focus of a funeral is God. It's an Easter liturgy. It's a liturgy of thanksgiving. It's a liturgy of our own hope. It's a liturgy that not only looks back with thanksgiving, it looks forward to our coming to the kingdom as well. And so it's a really, really important event. When you think about your funeral, the major thing to do is to give it enough skeleton to leave the family something to do. Instead of picking every hymn and every reading and every prayer and saying, I want this done at this time by this person, make a list. Here are my favorite Bible verses. Here are my favorite passages. Here are my favorite hymns. Pick 2, pick 3. It gives the family some structure and a framework in a time of stress so that they know that they're doing something that would be pleasing for you and satisfying for them. And if there's something you know that they might want to do and you don't care, tell them so. If you want to do this, that's fine. If there's something you really don't want done, I can think of 2 or 3 hymns that I absolutely do not want sung at my funeral. Say so. Say so. But funeral planning is not about morbidity. Funeral planning is about having a conversation with your spouse and your family. And children are tough on this one. You know, children sometimes are the hardest. The illustration that Derry gave of the kid that's lived for 5 years in California and hasn't had any connection with the family. It's amazing how many times therein lies the trouble. And the rest of the family needs to have something to say, no, what dad said was this, or what mom said was this, and so that's what we're going to do. And little brother or little sister can live with it. Yeah. But the thing to remember, enough structure to give some framework, but not too much structure so there aren't some choices. That they're going to be gathering because of you. And so in some way you want to give some indication of how you'd like them to gather, what you would like it to be like. And maintain the solemnity and seriousness of the occasion. This is a serious high point in life, to mark the death prayerfully of a beloved. And it's important. And your thinking can help you and your family and your clergy. We love to be helped. So do that. And remember that because of you, for your friends and family, in thanksgiving to God for the life that God has given to each one of us. So keep that in mind as you pray for your funeral, as you plan your funeral, and as you gather with you the people you want to have a conversation about your funeral. So that's all the time we have, but we do have time for a word of prayer. So let us pray. All glory, praise, and honor to you, most gracious God, for the gift of life and for the gift of hope that as we draw to the end of our life, we may rightly and duly prepare to pass through the gate of the grave into your kingdom. That you call us not to simply end life, but to move from the life here on earth which you have blessed for us into life in your heart which has borne our name forever. Grant us grace to be gracious in our thinking and in our planning. Grant us graciousness to be hopeful, to be joyful, and to look forward to that day when we are united with you in your kingdom. Through Christ our Lord. Amen. Thank you for your time and attention.
Unless everybody really needs to go, if somebody has a question, they're certainly welcome to answer. We won't keep you long, but if there's something that you'd like for us to, we have 3 wonderful people here who can answer your questions if you have one.
While you're thinking, somebody slipped a question to me a minute ago, and that was, are there different levels of hospice? There are different levels of hospice. Hospice can come into your home. Hospice can go into the nursing home or the skilled nursing facility and provide hospice services there. And then if you have an issue that would need hospitalization, rather than having go to the hospital, you can go to a hospice house, like the one that we have here on Statesville Boulevard, the Kaiser Hospice House. So those are the different levels. Also in the hospice service, you get 5 respite days if you have in-home hospice. And there's 5 respite days, I think, in a 90-day period. I'm not sure if I've got that right. But and so if everybody's just worn out and you need a break, you can go into the hospice house for 5 days to give your family a break and then come back home. So there's lots of different angles to it. But one of the things Karen told me beforehand, that she had no idea that hospice could go into the nursing homes. And yes, they can. So, okay.
Good.
Come up.
I can be loud. Is there any limit on time, knowledge?
Is there a
Limit.
I don't know if it.
Okay.
no, there's no limit on the question is there a time limit on how long you can be under palliative care? The answer to that is no. I actually asked that question when I was preparing for today because I didn't know. But the answer to that is no. It could be for years if it's necessary.
Did you say that palliative care is covered by Medicare?
Palliative care should be covered by Medicare, yes.
Just let's do this so everybody can hear those organs.
And one of the sheets that we have, it was talking about organ donors, and it stipulated where would you like this to go. But if you don't assign that and you have it on your license or you've indicated that, what is done then? Is it a decision at the hospital or?
There's a very defined process. Anytime, there is one organ donor association in North Carolina that does all of the organ procurement. So whether you've designated your body go to science or this or that, there's one organization that actually comes and does the organ retrieval during the patient's death. So at the hospital, if you're identified as an organ donor, the first thing that happens at death is, or near death, is they call the Organ Donor Association, and they come in and evaluate whether they can use any of your organs, tissue, eyes, skin, any of that, and then they take it from there and make all the arrangements on behalf of the patient.
We're talking about the shingles shot, and that's not covered by my medical plan. I have like a very fine United Health where I'm talking about the second shingles shot is not covered. And I'm thinking what we'd save in our hospitals and with our doctors if we didn't have that many people getting served for shingles problems. But is that in the works that maybe, it's pretty expensive, and I think there are a lot of people that don't get it because they can't afford it.
That is a big problem. The vaccine itself costs about $320 to $340, depending on where you get it. It's not available at your doctor's office because they don't supply us. We're not really sure why that's the case. We've been frustrated. That happened with the original shingles vaccine. Now, patients come in and ask me, I had the original shingles vaccine, do I need to get the new one? The CDC recommends getting the new one. The old one was 70% effective. The new one's 95% effective. Now, I've only seen 4 people with breakthrough shingles who had the original shingles vaccine. So I always tell patients, if you look at the shingles or herpes zoster, it's in the herpes family, like herpes simplex. People that get cold sores, you get a little ulcer, you get little bubbles on it. Those are vesicles, those are full of the virus. They can, if that happens on the body, we think of shingles. If you know what you're looking at and you have a high degree of suspicion, come in. If it's shingles, we can start you on the antiviral therapy right away. But that is a big impediment, and I don't see any changes coming down the pipe for that. It's very frustrating for us trying to get coverage for our patients.
Do we have other questions? I think they did an excellent job on these topics. Yes, please, you can leave your evaluation forms on the table back there or either in your chair. Please take just a few minutes. We need your help. And thank you for being here. You have made this everything it is. Thank you.